During the ASH meeting, I think we have a focus on Venetoclax. As you know, Azacitidine plus Venetoclax is now the new standard of care for acute myeloid leukemia, not eligible for intensive chemo, with a significant increase of median overall survival at 14.7 months. In the DiNardo publication, we observe an increase of complete remission rate in all cytogenetic and molecular subtype, but not in overall survival. So we need to continue to develop new combination with other targeted therapy or other immunotherapy to increase the overall survival in all subgroups. For the Azacitidine plus Venetoclax, one presentation was really interesting in IDH1 and IDH2 mutated patients, where we observed that the combination using Azacitidine plus Venetoclax is really efficient in this specific subgroup. It could challenge IDH inhibitor in monotherapy or in association. So I think we need a randomized clinical trial to validate the best option for this specific subgroup. We see also in the ASH meeting that the Venetoclax is a catalyzer of whole drugs, chemo or targeted therapy, and I could cite only one presentation. It's Venetoclax plus Gilteritinib, presented by Daver et al. And in this presentation, we observed a complete remission composite rate at 85%, even if patient were prior exposed to FLT3 TKI. And the median overall survival was 12.3 months in patients in relapse refractory acute myeloid leukemia. So I think the Venetoclax is really a good drug. So we could combine with Azacitidine, of course, but maybe also other chemotherapy or other targeted therapy. The last point I would like to discuss today is the beginning of the immunotherapy in acute myeloid leukemia, and the first immunotherapy in acute myeloid leukemia is the Magrolimab. David Salman et al. Presented the results of the phase 1 combining Azacitidine plus Magrolimab, a macrophage checkpoint inhibitor. This is a CD47 antibody, and we observe an overall response rate at 63%, including 42% of complete remission and 35% of minimal residual disease negative. And if we focus only in TP53 mutated patient, the overall response rate was 69%, including 45% of complete remission and 29% of minimal residual disease negative. The median overall survival was also high, 18.9 months in TP53 wild type patient and 12.9 months in TP53 mutated patient. So I think the Magrolimab will be included in the future in the treatment of acute myeloid leukemia, maybe in combination with Venetoclax and maybe other inhibitors.